مساء الخير. أنا سارة رأفت. Our case today, inshallah, is Mr. H.A., who's a 43-year-old male patient who's married and has a 2-year-old daughter, works as a salesman, and he lives in Allam, Alexandria. This patient presented to us at Alexandria Main University Hospital at the 14th of June, 2022, complaining of difficulty in breathing 1 day before he was admitted. The patient gave a history of a similar complaint that started 1 year ago, to which he sought medical advice at June 2021 at the Medical Research Institute and found to have elevated blood pressure and renal impairment. He was diagnosed formally as having increased blood pressure, hypertension. His readings were around 2020 over 120. For the renal impairment, he did an ultrasound renal assessment, which showed features of chronicity, and his urine analysis had active sediments of protein 2+, and RBCs 10 to 12, and granular cost of 2+. His quantification was about 4 grams, and his serum creatinine was 2 milligram per deciliter. PNC, ANCA, and C3 and C4 were all negative, so the patient was advised to do a renal biopsy. This biopsy was done at Cairo at August 2021, and the diagnosis based on the light microscopy was that the patient is suffering from thrombotic microangiopathy, most probably secondary to malignant hypertension. It also showed focal global glomerulosclerosis of 20% and moderate interstitial fibrosis and tubular atrophy of 30%, denoting element of chronicity. I'm not going to go into further details in the biopsy, as Dr. Maram will explain thoroughly. The immunohistochemistry of the primary biopsy was also negative. Back to the history, the patient prior to this year reported only having chronic tension headaches, while in the last year, the patient reported that he was admitted repeatedly to the hospital due to hypertensive pulmonary edema and increased renal function. Usually that resolves to the baseline creatinine level of 2.5 to 3 milligram per deciliter. He had never done any surgical procedures, and he was only taking his antihypertensive drugs as well as over-the-counter analgesics from time to time. He's a smoker, and he smoked 1 pack a day for the last 20 years. The hallmark of the clinical examination when the patient was admitted to us is the elevated blood pressure. His blood pressure was 200 over 140 in upper limbs, while 220 over 150 in lower limbs. Otherwise, he had normal examination almost. His urine output was good to about 2,500 milli per 24 hours. He was admitted first at the ICU to receive intravenous nitroglycerin. Then, after blood pressure control, he was referred to our ward. These are the labs that had been done at the primary admission of the patient. As you can see, he had normal anemia, normal platelets count, normal white count, markers of infection were negative. His serum creatinine was elevated from the baseline, reaching 6.4. Otherwise, every other lab was normal. His thyroid profile was normal. His virology screening, however, in virology screening, we discovered that the patient had HBV surface antigen positive, and we asked for PCR for hepatitis B, D, and A. The results are still pending. We repeated the urine analysis, again, active sediments, and the quantification was the same. So in this case, based on the previous history, we had 3 questions we needed to tackle. Is this a case of acute kidney injury on top of chronic kidney disease, or we're facing progression of the previous chronic kidney disease that the patient had? The question number 2 is why the patient's blood pressure is so difficult to attain control even though he was compliant with his antihypertensive medications, and why it was fluctuating from time to time. And the third question was that we have to look for other end organ damage, because as the patient obviously came with renal impairment, maybe other organs were affected too. We repeated the ultrasound renal assessment after excluding pre-renal and post-renal causes. Again, signs of chronicity were seen, but it was obviously not it's not enough to diagnose the progression, so the patient was advised to do a renal rebiopsy. Now Dr. Maram will explain the finding in the biopsy. The next presentation, please. البرزنتيشن الثانية من فضلك.
Thank you. Okay, as regards this case pathological findings, microscopic examination of serial sections from the submitted renal core biopsy stained by H&E, PAS, trichrome, silver, and congruent stains revealed the presence of one corticomedullary renal tissue core featuring 9 glomeruli. 4 of them were globally sclerotic, and the remaining viable glomeruli feature uneven GPM thickening with double contouring with mild increase in mesangial matrix and average cellularity. Again, here we have this GPM thickening with double contouring, and one glomerulus was shrunken with double contouring, again the same findings. 2 glomeruli feature segmental necrotic lesions. As regards tubulointerstitial compartments, the interstitium features moderate mononuclear inflammatory infiltrate with marked interstitial fibrosis involving about 70% of the submitted cortical tissue. The tubules feature marked atrophy with reactive tubular dilatation. As regards the vascular compartment, the blood vessels feature marked arteriolosclerosis with mucoid intimal hyperplasia. Also, arteriolar onion skinning were detected. Congruent stain was negative. By ultrastructural examination, it revealed mesangial interposition with GPM duplication with new GPM matrix material deposition. Again, mesangial interposition and duplication of the GPM with no electron-dense deposits. So the combined morphological and ultrastructural findings are diagnostic of chronic TMA, secondary to malignant hypertension, with global sclerosis in 4 out of 9 glomeruli, segmental necrotic lesions in 2 out of 5 viable glomeruli, severe interstitial fibrosis and tubular atrophy involving 70% of the submitted cortical tissue, moderate interstitial inflammation, severe arteriolosclerosis with onion skinning with mucoid intimal degeneration. Now I'm going to talk briefly about the differences between the previous biopsy and our biopsy as regards chronic TMA versus acute versus chronic TMA. By light microscopy, very important to find intravascular fibrin thrombi in acute TMA, while in chronic TMA, double contours of GPM with variable endocapillary hypercellularity with no immune complexes, intravascular fibrin thrombi again with mucoid changes in the acute phase, while in the chronic phase, arteriolar onion skinning is very evident. As regards ultrastructural examination, subendothelial widening by electron-lucent fluffy material in the acute phase, while in the chronic phase, we are going to find mesangial interposition with double contouring. These are the main differences. And as regards the differential diagnosis of chronic TMA, it depends on, mainly on the presence of double contouring and variable endocapillary proliferation. So it's mimicking MPGN, but MPGN should show disease-specific staining for immunofluorescence and deposits by electron microscopy. The second, in cases of transplantation, transplant glomerulopathy in chronic antibody-mediated rejection, it shows also double contouring of the GPM by ultrastructure, and often it should be associated with donor-specific antibody and C4D positivity and peritubular capillaries. As regards our case, malignant hypertension associated TMA, the lesions are mainly evident in the arterioles and interlobular arteries, while in HUS, predominantly the lesions affecting the glomerular compartment. Thank you.
Okay. So based on the comparison between the two biopsies, we can see progression in the chronicity element. So this is favors that the patient had progression of his previously diagnosed chronic kidney disease rather than this is being an acute insult. The second question that we had to answer is what is the cause of the uncontrolled blood pressure that our patient was showing? At this time, our patient is on the maximum dose of the following antihypertensive drugs, bisoprolol, nifedipine, sustained release, clonidine, doxazine, and later on we added aldactin 200 milligram, ramipril 10 milligram, and the patient still till now on and off on nitroglycerin, whether it's a dermal patch or intravenous infusion, and also he received intravenous shots of phentolamine. Till this day, he's not fully 100% controlled. According to the criteria of the American College Cardiology to screen for secondary hypertension, our patient fulfilled more than 2 or 3 criteria of these mentioned. So we had to look for another cause rather than just simply hypertension, primary hypertension. The first category is coded red. These are the more common. Secondary, the second causes are coded yellow, least common, and lastly, brown in brown color, the least common causes. We started with looking for renal parenchymal disease. Of course, our patient had an element of renal parenchymal disease. And for renovascular disease, we did an ultrasound Doppler assessment for renal vessels, which came back normal. We did a 24-hour urinary metanephron to search for pheochromocytoma, which is pending results. And the echoes show no signs of coarctation of the aorta. As for screening for primary hyperaldosteronism, it was warranted to do because later on the course of admission, our patient started to develop hypokalemia. However, to do the test of plasma renin and aldosterone ratio, the patient should keep 6 weeks free of RAS blocker drugs. And nowadays, with the very fluctuating blood pressure, this is still difficult to do. The third question was to look for other end organ damage or target organ damage. As we all know, the malignant hypertension not only affects the kidney, but the heart and the central nervous system also could be affected, ranging from the early stages of proteinuria to end-stage renal disease, affection of the coronary artery disease, coronary vessels, in myocardial infarction, diastolic and systolic dysfunction ending in congestive heart failure, and arrhythmias. As well as for the central nervous system, we can start with retinopathy and end in stroke. All these, if left untreated, could lead to death. In our patient, we did a fundus examination, which revealed a retinal hemorrhage of a grade 4, and he was recommended to do a further OCT. For echocardiography, it revealed moderate LVH, grade 1 diastolic dysfunction, and preserved ejection fraction. His ECG, at early admission, it showed signs of LVH, while later on the patient suffered from chest pain, and ECG showed inverted T waves as well as elevated cardiac enzymes. And this is when our patient was diagnosed to have non-STEMI, and now he's recovered, planning for future PCI. So to conclude, our patient is a 43 years old male patient who came to us presented with increased renal functions on top of chronic kidney disease, and he had nephrotic range proteinuria. His renal pathological diagnosis was chronic TMA related to malignant hypertension. The patient is hypertensive grade 3 according to European Society of Cardiology, or hypertensive crisis according to the American Heart Association, and he has features of end organ damage. The patient showed criteria of secondary hypertension, which is still under investigation. Now, Rawan will continue the commentary.
Assalamu alaikum. Will I comment on chronic TMA? What is TMA? Thrombotic microangiopathy starts by endothelial injury that results in platelet aggregation and the consumption of platelets and non-immune thrombocytopenia, and also mechanical fragmentation of RBCs that result in microangiopathic hemolytic anemia, which is presented as anemia, schistocyte and CBC film, high bilirubin and LDH, and low haptoglobin. And this all results in microvascular occlusion and ischemia and end organ dysfunction that result in, again, endothelial injury and vicious circle. What is the classification of TMAs? There is a classic classification of primary and secondary causes. According to presentation, we have systemic TMA and renal limited TMA. According to onset, there is acute and chronic TMA. This is, we'll start by classification, primary and secondary. The most common cause of primary, atypical HUS and TTB, which could be hereditary or acquired, but it's not our case. We'll go for secondary causes. The most common are malignant hypertension, drug-induced autoimmune disease, infection, malignancy including monoclonal gammopathy and solid organ transplantation. Some of drugs causing TMA like CNI, quinine, tamoxifen, plomycin, cisplatin. There is a cohort for patients presented with TMA to view the causes and the percentage of each.
from 4 hospitals in France, including more than 500 patients. 6% had primary TMA and more than 90% had secondary TMA. The most common cause for secondary TMA was pregnancy-related and infection and drugs, and malignant hypertension represented 4% of patients with secondary TMA. Regarding the second classification, systemic and the renal limited, systemic means the presence of triad of microangiopathy, hemolytic anemia, thrombocytopenia, and end organ damage. Renal limited TMA, this term used when characteristics thrombi and histological changes found in biopsy for patients presented with renal dysfunction, but there is no systemic manifestations of TMA. So it's a histopathologic diagnosis. There is a cohort for patients presented with TMA. They correlate the patient correlate the histopathological finding مع الكلينيكال برزنتيشن بتوع البيشنتس اللي كان معاهم systemic TMA او الرينال ليميتد. دول تقريبا كانوا 33 native kidney biopsy فيهم TMA و7 patients graft biopsy. الجرافت كانوا كلهم CNI وانتي بودي ميديتد ريجكشن. النيتيف كدني كان most common cause of malignant hypertension followed by pregnancy and lupus nephritis and atypical HUS. And the most postpartum cases of TMA and atypical HUS had systemic features of TMA. On the other hand, malignant hypertension and lupus nephritis presented with isolated renal TMA, which emphasize the importance of careful evaluation of patients with renal biopsy in absence of systemic features of TMA. There is another cohort for the patients that had renal limited TMA without any systemic features of microangiopathic hemolytic anemia, and all native biopsy where there was no transplant of them. From 35 patients, 18 was females, all had renal limited TMA. Creatinine was about 2.4. TMA represented تقريبا 50% of patients that had chronic TMA, and 3 had finding of chronic and acute TMA. And the most common etiology of renal limited TMA was drug induced followed by autoimmune disease, and 6 patients had unknown cause. However, 50% of patients improved with plasma exchange. Another point of renal limited TMA is the presence of TMA with another glomerular pathology such as the ANCA-associated crescentic GN and MVGN. Also in patients that had renal allograft, the most common causes of TMA are antibody-mediated rejection and CNI toxicity and recurrence of the primary cause. When to biopsy patients, I mean patient already had renal limited TMA to identify the extent of ischemic irreversible injury, and for decision making for patients that had already therapeutic immune suppression but without improvement. Regarding the onset acute or chronic, there is a histopathological differentiation as Dr. Maram showed, and I want to go through. On the other hand, the clinical presentation for patients who are acute and chronic. The acute is the most common presentation, which is easily diagnosed and managed. However, pathogenesis بتاع الكرونيك TMA والجايد لاينز يعني تقريبا مفيش جايد لاينز خاصه بيه ومفيش عليه ريفيو قوي في الليتريتشر، فويل جو ثرو فيري ليميتد داتا. ده ريبورت كان بيتكلم على الحالات الاتيبيكال HUS اللي بريزنتد بكرونيك TMA في البايوبسي فروم ذا ستارت. كانوا عملوا اناليسيز للكومبلمنت ديسريجوليشن اللي معاهم والجينيتيك اناليسيز بتاع الكومبلمنت، ولقوا ان في بعض الميوتيشنز في السي 3 اللي بتبقى اسوشيتد مع البروتينوريا والكرونيك TMA. however العينين بتوع الكرونيك TMA بتوع الاتيبيكال HUS دول ما تحسنوش خالص على الكومبلمنت انهبيشن ثيرابي. Coming to malignant hypertension induced renal TMA, about 25% of patients with malignant hypertension had TMA. The problem here is the pathogenesis is complicated. It's not only the sheer forces of hypertension that cause endothelial injury, but also some patients with malignant hypertension had genetic variants of complement mutations, and also there is hormonal factors. This result in diagnostic challenge. Is it only malignant hypertension or it concealed atypical HUS, which will affect therapeutic options? And we will go for controlled blood pressure only or giving immune suppression? And what about transplantation outcomes?
Dear doctor, your time is up.
انك بتتكلمي بسرعه 120 ميل في الدقيقه. احنا يعني مش قادرين نتابعك الحقيقه.
طيب حاضر. هو انا بتكلم على الباثوجينيسيس بتاع البيشنتس اللي بريزنتد بمالجنت هايبرتنشن وكان معاهم كومبلمنت ديسريجوليشن. فده ريبورت كان بيتكلم على تقريبا 7 يعني بريزنتد بكلينيكال برزنتيشن اوف مالجنت هايبرتنشن ومعاهم ايفيدنس اوف اند اورجان دامج، وكان معاهم مودريت تو سيفير كدني انجري، والبايوبسي كان فيها رينال ليميتد TMA، ولكن كان معاهم بوزيتيف كومبلمنت ديسريجوليشن سواء C5B9 في السيرم او في رينال ديبوزيتس. والبيشنتس دول اغلبهم او تقريبا يعني 90% منهم بعد الترانسبلانتيشن حصل لهم ريكرنس. فهو عايز يقول ان البرزنتيشن بتاع مالجنت هايبرتنشن ممكن يكون اتيبيكال HUS بس مش دايجنوست. تاني نقطه في جيناتيك فاريانس لقوها في العيانين في الكومبلمنت جينز في العيانين اللي معاهم سكندري تي ام اي زي عيانين البرايمري تي ام اي، بلس ان في فولس بوزيتيف ونيجاتيف ريزلتس، فانا عشان كده مش بقدر احكم ان العيان ده برايمري او سكندري اكوردنج للكومبلمنت جيناتيك ميوتيشنز. ده ريبورت تاني من الجيسن بيقارنوا بين الكومبلمنت ديسريجوليشن اللي لقوه في العيانين اللي معاهم اتيبيكال اتش او اس او مالجنت هايبرتنشن او التي ام اي في حالات الهيلب والبري كلامسيا، لقوا في 7 سي 5 بي 9 ديبوزيشن في عيانين الهيلب وعيانين الاتيبيكال اتش او اس، لكن عيانين مالجنت هايبرتنشن ما كانش فيهم ديبوزيشن. فهو ملخص الداتا اللي موجوده في الليتريتشر مش كافيه ان احنا ازاي نفرق بين المالجنت هايبرتنشن والاتيبيكال اتش او اس وتجايد فورزر مانجمنت. الخلاصه بتاعت الكلام لو العيان البلاد بريشر بتاعه عالي ناحيه ومعاه اكتر سيستميك مانيفستيشنز قليله بتاعت الثرومبوسايتوبينيا والانيميا واتحسن على البلاد بريشر كنترول، غالبا ده مالجنت هايبرتنشن ومش هعمل له اميون سبريشن اكتر من كده. لو كان في فيرذر اون جوينج تي ام اي مع البلاد بريشر كنترول يبقى انا المفروض ادي كومبلمنت انهبيشن. وفي بعض الكلام على ان انا بدي كومبلمنت انهبيشن برضه في عينين السكندري تي ام اي لو كان في معاهم ايفيدنس اوف جينيتيك ميوتيشن للكومبلمنت، حتى لو انا مش متاكد ان هم اتيبيكال اتش او اس. بس